So it is, what is today's date? The second, I believe, right? Yeah, it is the second. I am still in Virginia. So huzzah. And we're going to talk about goniometry and kinesiology today. And we're also going to talk about manual muscle testing. I should have added principles of goniometry and manual muscle testing to the main screen, but I, much like most of my ADHD brain, forgot to put that on there. So we're also going to talk about the principles or basics of manual muscle testing. We're not actually going to talk about the actual manual muscle test individually yet. So, PROM, AROM, AAROM, FROM, by the end of the semester, you better know all of these. These are going to be your principal kind of guiding ideals going into your first clinical. So by the end of the semester, you guys should be waking up going, PROM is passive range of motion where the patient does nothing. AROM is where the patient does some of the work, but something else helps them. AROM is where they do it fully, and functional is where they are able to perform functional tasks with their range of motion. What? Huh? Right? Some of you probably are already starting to do that, but that's kind of important to understand. Bony lockout is an important term to kind of understand. A bony lockout are joints that have the ability to lock into either full extension or full flexion, and the bones lock into a bone-on-bone intersection. There are two main joints that have a bony lockout. What's one of the ones we've talked about before? The main one that has a bony lockout.
The elbow?
The elbow, yeah, right? That olecranon, locking into the olecranon fossa, right? The knee also has a little bit of a bony lockout, and we'll talk about the screw home mechanism in the knee. So it's not the same as the olecranon, right, sucking into that fossa, but because when the knee comes up and it screws and locks into place, it has a bony lockout as well. So what does that mean? You can actually lock your knees out and eliminate muscle control if you can get to full extension, right? So that's why we're going to talk about, you're not going to want to test somebody in full bony lockout. Resistance is obviously a concentric force that acts in opposition. So if you're holding a dumbbell, right, the resistance is holding that dumbbell and lifting it up. I'm going to tilt the camera down just a little bit. Now my top of my head's not showing, but oh well, that's life. Line of pull is the way that the actual resistance is being pulled, right? So line of pull for muscle, elbow flexion is going straight up and down. Braking is what we're going to be concentrating on. Now, when I say braking, I'm not talking braking as in actually physically breaking the patient. That would be bad. Hold on one second here. Give me 1 sec. All right, sorry about that. Had somebody pop in here real quick. So braking is the point at the range of motion where the muscle is most challenged, right? That's the place where the patient is going to hold that position and not allow us to break them. So I don't like to use that term with patients because when I say, don't let me break you, that kind of sounds bad, doesn't it? Think about that. If I'm a big scary therapist and I walk up to Truman and I'm like, okay, man, I want you to hold the arm up in the elbow flexion and don't let me break you, man. Truman's gonna be looking at me like, what are you talking about breaking me? Don't you dare break me. Right, so you have to be careful. It is a break test, right? But you're not physically actually breaking the patient. That would be bad, again. Active resistance tests are applying manual resistance at the end or against an actively contracting muscle, right? So I made all kinds of languages there. I'm horrible at voices, so I just make things up as I go. Don't worry. I'm great at that. I combine German and Jamaican to make Jamaican. You're making me hungry. That's what you're doing. You're making me hungry. So when we do an active resistance test, that means the patient is going to be doing active contractions. I don't know why we have to talk about this. I'm not exactly sure what a passive resistance test would be, other than maybe a stretch. And I've never actually quite understood this in the book because, like, if the patient's contracting, it's active, what else are we going to test? But hey, The book basically is saying that we're going to apply a manual resistance until it reaches a maximal level the patient can tolerate. One of the key things I'll talk about with manual muscle testing is remember that you are testing the patient, not your own strength, right? I guarantee with a good chunk of you at least, maybe not Joe, Joe's kind of swole, I'll be able to break most of your muscle resistance, right? Just by using my own body weight as resistance and pulling. That's not the goal. The goal is not to test how strong I am. The goal is to test how strong you would be as the patient. So just be aware of that and think through that. Some of the things that will occur with this, we talked about collagen already a little bit. Adhesions are when muscles stick down to things. So what can muscles stick down to form an adhesion? What do you think?
Like in your body? Like
yeah, inside your body, yeah.
Like your tendons?
Tendons, good, right? The tendons can stick down to things. They can stick down to the fascial layer, right? Between each layer of our bodies, we have a thin layer of kind of a fatty substance that allows gliding. They can stick down to that. They can get stuck down to bone. So when we have those adhesions, obviously it's not going to allow a muscle to contract as well. A contracture is exactly like it sounds. We talked about that. That's where our muscle's fully contracted. Most of these we talked about a little bit yesterday, right? Creep phenomenon, Golgi tendons, all of that. All of that is going to come into play with this. That's why I kind of review these when we go through this. So when we're measuring angles created by joints and bones of the body, it is goniometry. This is probably one of the simplest and most basic tests that we do in physical therapy. We place parts of the measuring instrument, the goniometer, along the bones, along the proximal and the distal joint, and we measure the distance of motion of those joints. It's an important part of a comprehensive evaluation, examination, and it also is good for follow-up. It helps us guide if we're getting improvements. We can measure it both actively and passively, right? I can move a patient through a range of motion and see how much range of motion they have, and then they can move it through. And most of the times we find that passive range of motion is a little bit further than active. And that's just because when you start contracting and causing your muscles to get a little swole, sometimes you create a little bit of resistance on there versus just somebody passively moving you through that range of motion. The important part, again, is to measure and document, right? Documenting should become part of your life from now on. So again, we can measure active, we can measure passive. The other thing we can measure is functional mobility. Are they able to, again, become functional with their range of the motion? We use a 0 to 180 degree scale for sake of ease and standardization, but there's really only, I'm trying to think through it. There's only really 2 joint motions that reach 180 degrees. Does anyone know what those 2 joint motions are that reach 180 degrees?
Arm and hip abduction.
Whoa, hip abduction 180 degrees? That'd be pretty impressive. That means your leg's up by your head.
I've seen it.
I mean, I guess, but that's not normal. I'm definitely not there. There's 2 where it is normal. I'll answer your question in just a second, Diana. So shoulder flexion is a 180. And what other motion goes along with shoulder flexion?
Elbow extension.
Okay. Yeah, elbow extension. So that's the interesting one. Elbow extension actually is a 0 degree measurement, believe it or not, because elbow extension means it stops at neutral. We'll talk a little bit about that when we get to the elbow. The elbow is a weird one, right? The other one is abduction. Both of those consider normal shoulder abduction, shoulder flexion as being 180. Almost all of your other joints in your body are less than 180. And extension is only about 60, honestly, or well, for normal people, I can get to like 30. I'm just tight. And Diana asked a great question. Would you measure before and after treatment? You absolutely could. If you want to see if you're getting somewhere with your treatment, that could be a really valid measurement, right? Especially if you got somebody that's got like frozen shoulder adhesive capsulitis. You could assess exactly for your assessment if your exercises are leading to a little bit more improvement, especially if the patient came in and said, you know what, Diana, after our session yesterday, man, I was doing my dishes and I could put them away on my top shelf. And Diana's like, So let's take a measurement at the beginning and see how you are at the end of the session and see how much you improve. And we could definitely put that in assessment then showing, hey, look, what we're doing is working. right? It may take a little bit of time to build up, but it's definitely working. Center myself a little bit better. There we go. So there's some disagreement in practice about recording hyperextension and extension lags, right? Extension lag is where a muscle can't reach full extension. So be aware of it. Clinics vary in their documentation preference. For our numbers, for us, we'll use specific numbers. Ask your CI what they may use. So in the case of an elbow, when I lock out, I should be at 0 degrees when I'm all the way out there. This should be a straight line. It can also be 180 if you're thinking about it in a straight line process, but we consider extension as our 0 point, and our flexion is where we're going to get our actual angle point. Well, what happens if I go beyond 0? Well, some people will say that if I go beyond 0, I actually have a negative extension, meaning that I'm going to document it in a negative form. So sometimes in certain clinics, what you'll see is something like, you can bring my little drawer over here, something like this, where it's like -5 to 135 degrees in the elbow. What they're saying is I have 5 degrees of hyperextension and 35 degrees of flexion, 135 degrees of flexion. I don't like this, and most clinics are getting away from this type of writing. Why? Because this minus sign and this sign in between get confusing. Because I could look at this as -5 and -135. That doesn't tell me anything. So a lot of clinics are going towards this style of writing here. And what this is saying is, in this joint, you have 4 degrees of hyperextension. Obviously, if you have hyperextension, you can reach neutral. And then you have 135 degrees of flexion. Now, good news is not all your joints require this kind of a writing. The elbow kind of does, shoulder does a little, the knee does a little, some of your fingers do as well. But most of the time, you're just going to write it in the terms of something where you're looking at going, well, my elbow flexion range, right? So my elbow flexion. I'm not even caring about my extension there, and so I'm just going to say it's going from 0 to 120, right? Or I'm talking about shoulder abduction. It's gone from 0 to 95 or something like that. When we write it like this here, where I'm talking about where we've got those 3 numbers, that's including any hyperextension plus getting to neutral plus getting to the flexion point. A lot of your new systems, such as Clinicent, such as WebPT, they just ask for the measurement for extension, the measurement for flexion, and you just put the number in there. So let's say you measure my elbow extension and I have 4 degrees of hyperextension. You'll just put, it'll say hyperextension of the elbow. You would put 0 if I had none. If I have 4 degrees, you put 4 degrees. And then it'll say flexion of the elbow. Put the flexion in there. And you're all done, and the system takes care of it. Where this used to get really confusing is when we did written notes, more kind of handwritten notes. And for the most part, most of our clinics in the Valley are now using electronic health records, which make things a lot easier, to be 100% honest. But you can see down here, this one, right? That's confusing. Like 0-6-125. What does that even mean? Right? Because that makes no sense. That looks like the person has 0, is locked out, but then gets stuck at 6 and then goes 120. No, right? 6 to 125 degrees. For me, reading that, right, it is very confusing. Exactly, Riley, right? What about that 6 to 125 degrees? How would you read that?
I would read it as, like, if I didn't know, I would read that as positive, so they don't fully extend.
Right. And that's the way I read it. And I actually took this from one of our CIs that sent us some sample notes over, and they were saying the patient had 6 degrees of hyperextension. And that's exactly the way I would take it. I was like, oh, they're stuck at 6 degrees of contracture, right? And so they can't even get full extension. That's greater than 6 degrees. 6 degrees is out there. And I'm like, well, no, that's the way we document hyperextension. I'm like, that doesn't, again, not good. So for your soap notes, if you want to make things clear, you want to make things easy on yourself, it's okay to just go, well, you know what? I'm going to make it simple on myself. And what I'm going to do is I'm just going to say, here's my extension number. Here's my flexion number, and just break it down and make it as bone simple as you possibly can. That's okay. It's also okay if you wanted to combine it and say here's my hyper to neutral to flexion. If you wanted to write it that way, that's okay too, as long as you are consistent with the way you write your notes. And as long as once you get out in the field, you stay consistent to what your PT does. Right? If your PT does negative numbers, okay, follow your PT. I will say that most PTs aren't doing that anymore, but there are still some, especially when you get out there and, some of the PTs that have been in the field as long as I have still do negative numbers. So they exist. Capsular patterns are probably the most difficult thing you guys are going to have to understand in this semester. And I guarantee by the time we get to semester 5, these are going to be the number one thing you guys are still like, I just don't get it, Mr. McKeever. Capsular patterns don't make sense to me. Did Dr. Johnson talk a little bit about capsular patterns in intro?
Sounds familiar, but I don't remember.
Yeah, sounds familiar. At least that's something. I'll take it. So, and this is interesting because teensy tiny bit, I like that. Right? This is the interesting part about capsular patterns that kind of amuses me is this statement here. Where is it? Capsular patterns are based on clinical findings rather than research. What that's saying is not everyone believes in capsular patterns. And if you actually ask Dr. Sokel, she's not sure capsular patterns exist according to her treatment patterns and everything she's done. I would say capsular patterns absolutely exist. And if you talk to Dr. Reskin, there's who I'm talking about, she feels capsular patterns exist. So it just depends upon kind of what your exposure has been. But what a capsular pattern is a very joint-specific pattern of restriction of passive movements. It can affect their active movements as well, but it's definitely in their passive. So when you start moving them through passive, they start having this very kind of characteristic pattern of limitations. The presence of a typical pattern in the joint if the capsule of the joint is affected. So the capsule of the joint is the actual parts that hold the joint together. Not necessarily the muscles and the tendons. It's all those little ligaments and stuff that hold that joint together. If you ever looked at the hip has all these ligaments that kind of wrap around the head of the hip. And they kind of make this ball around the hip that hold the ball of that femur into the acetabulum. Each joint has a very characteristic pattern of limitations. Now, for your boards, they do expect you to kind of have the general knowledge of capsular patterns, specifically of stuff like the elbow, the hip, and the knee. So that's some good news. Once you get on the clinic, if you specialize in something like hands or specialize in spine, you do have to know the capsular patterns of the spine or the hands. What typically causes these things? Osteoarthritis, problems with the joints themselves and the bones. Spondylitis, stenosis, spondylolisthesis, and we're going to cover both of those this semester, so don't totally freak out if you don't remember what they are. RA is a big common problem that causes these capsular patterns, as well as traumatic arthritis, meaning arthritis developed due to a trauma pattern. Whiplash in the neck, and an ankylosing spondylitis, where we get something blocking off a bony block, for sure. So again, it's based on clinical findings, meaning we base capsular patterns on what we see, not necessarily what's been researched. Now, there has been research into capsular patterns that kind of develops what the normal capsule patterns are for each joint. But again, this is one of those hot topics. And when I say hot topics, it's not an exciting topic, but it's one of the hot topics in PT where some people say, Capsular patterns are nothing more than a non-capsular pattern that occurs in a weird way. It is kind of similar to end-field, except end-field we all agree on, John. That's the weird part. So John asked if it's similar to end-field. End-field, we all agree on end-fields are different. But for whatever reason, capsular patterns will have a specific end field where they end before they should. So like we're going to talk about, I have a couple of them coming up. We're talk about like what does a shoulder capsular pattern look like? Why is this important? First of all, that's a big question everyone asks. Why do we need to know the difference between capsular and non-capsular patterns? It'll drive our treatment. So if I have a capsular pattern, I want to mobilize the joint. That means I'm going to do joint mobs, right? And I know that you guys are in Nevada. That's not moving a joint from table to table. Joint mobs are where we are going to mobilize the joint without necessarily moving them through range of motion. The most kind of aggressive joint mobs are those nice pops and cracks we do, right? Those are grade 5 mobs, but there are 4 grades before that. And we find with capsular patterns, if they have a very specific pattern that they respond to, that if we do joint mobilizations and kind of loosen up all those ligaments and tendons holding that joint together, we can regain range of motion. Whereas if patient has non-capsular patterns, we're going to treat the muscles and bones as we see them. So maybe we have to stretch muscles, maybe we have to strengthen muscles and bones, right? But at that point, it's not the actual capsule that holds the joint together, it's everything else. It's the muscles, it's the muscle strength, it's maybe the muscle length. So then we're going to treat it in a different manner. If we have a non-capsular pattern and we mobilize, a lot of times we get no results out of it. Now, does that mean that, my PT says this one time they had a non-capsular shoulder flexion problem and they mobilized the joint and got some range of motion out of it? Well, great. That's the 1 in 1 million shot, right? Typically, if you have a capsular pattern, we're going to do joint mobs. If you have a non-capsular pattern, we're going to do stretching, strengthening, range of motion type of stuff like that. So non-capsular patterns are joint limitations that exist but aren't capsular in nature, isn't capsular in nature. So this could be caused by bursitis, disc lesions, facet joint problems, thoracic outlet syndrome, right? TOS is thoracic outlet syndrome. I put that on there and then I realized just a second ago, maybe you guys don't know what that is. Do you guys know what thoracic outlet syndrome is?
No.
Where do you think that occurs at?
The thoracic.
The thoracic outlet, good, right? That's up here where all those blood vessels and nerves pass out to the arm, right? So if I have a problem up there, that could limit my range of motion because maybe I'm not getting nerve issues, maybe I'm not getting blood. If that's the case, I need to treat this. Mobilizing this joint's not going to do anything if my problem's here, right? Does that make sense? My problem is that my anterior scalene and my middle scalene are completely pinching off my thoracic outlet. Going out here and moving the shoulder is not going to do anything. Well, I can mobilize the shoulder all I want, Bobby, but it's not going to do anything. I've got to take care of the problem up here. Typically, if you have a non-capsular pattern, it's going to be limitations in a single or maybe a secondary joint motion. So you may have something where it's limited in flexion and extension. We'll talk about the different motions that get limited in capsular patterns. So a good example of a non-capsular pattern is if you long sit, so where you're sitting upright and your legs are straight out in front of you. When you sit like that, because of the way the gastroc is laid out, being a 2-joint muscle, it's a lot harder to get dorsiflexion than it is if your knee's bent. That would be a non-capsular patterns. So for non-capsular patterns, we're stretching, strengthening, and then dealing with any other type of stuff that we might have to deal with, bone problems, nerve problems. There's a lot of other stuff that can come into play with it, Riley. That's why, stretching and strengthening is going to be our primary treatment there. We're just not going to mobilize the joint, if that makes sense. So the main idea here is for non-capsular, don't mobilize. For capsular, mobilize. Does that make sense? So again, if you have a test question from Mr. McKeever that says your patient presents with a capsular pattern, you should go down into the answers and look for what? Mobilization.
Mobilization.
You got it, right? And then we're going to figure out in one of our classes when we practice joint mobs, because we are going to practice them. Yay. We just won't practice grade 5s because we don't do grade 5s. I will explain them. I may have one of the DPTs demonstrate a grade 5, but we will not perform them. So mobilize with capsular, don't mobilize with non-capsular. Beat that India. And again, we're going to talk about, in this, I put together some charts here for you that kind of talk about how a capsular pattern looks. So in the hip, right? A blocked position, if you had to think about a blocked position, what do you think blocked position also translates into? What's that other term for a blocked position?
Closed, maybe?
Closed what?
Closed pad?
Closed pad. Good. Yes. Good job. Right. So our blocked position here is our closed pack position. That's our position of what? Stabilization or mobilization?
Stabilization.
Stabilization. Good. That means our relaxed position is our open packed, and that's where we're going to mobilize. So our capsular patterns of the hip, like we're just looking at the hip and we're going, well, is this capsular or non-capsular? Typically, if the patient has limits in flexion, internal rotation, and abduction, so a combination of all of those, it's a capsular pattern. If the patient has problems in maybe flexion and external rotation, it's usually non-capsular. Does that make sense? That's kind of what we're looking at here. And we're going to go, again, don't memorize this chart today. We're going to go down through as we go through each joint, what the capsulars look like and what the non-capsulars look like. I just try to put it in one large chart for you guys. That way, when you're getting ready to not only study for this, but also maybe a good idea would be to take this and put these three, I think it's 3 pages total, right? 1, 2, 3. Where might be a good place to put that?
In your binder?
You got it. In your clinical binder. Perfectly. And I like the jazz music in the background. That just goes right along with it.
Sorry, Mr. McHugh, I got a question. Going back to that, like the example that you give out on the hip, you said if it's like flexion, internal rotation, and abduction, that would be a capsular pattern.
Yes.
But if flexion, external rotation, that would be a non-capsular.
It typically would be a non-capsular pattern. Yes.
So is it like dependent on like the rotation of the joint?
Well, it really just depends upon, so you have to think about the way the joints are laid out.
Mm-hmm.
And the capsules themselves are more preventative to prevent you from going into external rotation than internal rotation. So what happens is if that joint capsule gets tight, it's going to bring you kind of stuck into internal rotation where you're going to be limited in it, or limited in the motion. Actually, let me rephrase that. I totally backwards that. My brain just poof. So it's going to limit it's going to limit that motion where you're not going to get that internal rotation going on, but you might be more externally rotated like I am with my hips, right? Mm-hmm. I have a non-capsular pattern on my hips. Mobilize my hips isn't going to fix my internal rotation. I'm just stuck in external rotation because I'm looser that way and tighter the other way. That's kind of the idea with a capsular pattern is typically if you have a non-capsular pattern, it's usually caused by muscle tightness. Right? It's not caused by the capsule itself. So all those little structures that are holding the ball of the femur in there getting stuck and down. It's more talking about maybe, okay, it's my rectus femoris that's tight. Does that help make sense of it?
Yeah. So yeah, just a bit. So how would you figure out like the difference between like, do you just test it if it's a capsular pattern or a non-capsular pattern?
Yeah. So what we do, let's look at the knee because the knee is an easy one to kind of break it down here. The knee, if you have a capsular pattern, is limited equally in both flexion and extension. What that means is if I take a patient through passive range of motion and they have limits in flexion and they have limits in extension, it's likely that the knee joint itself has a capsule problem, meaning all those ligaments that hold the knee together are really, really super tight. Mm-hmm. Whereas if instead I have an extension problem, right, where I'm stuck in a little bit of flexion and I don't have any flexion, I can flex the whole way back to my butt and have no problem. But I'm missing that last, say, 15 degrees of extension. At that point, it's not all those ligaments that are holding me back. It's my hamstring.
Okay.
right? And so I have to stretch out my hamstring and worry about that. Whereas if I had both of them limited, I go, let's try mobilizing not only the kneecap, but the knee itself and see if we can get equalized out on flexion and extension.
So all of these have to apply for it to be a capsular pattern. If it's not, then it would just be more of like your muscles or your.
It would be a muscle imbalance typically, right?
Okay.
Right. It could also be some bony block problem. Like there are other things that could go along with it as well. But typically in the physical therapy setting, it's going to be a muscle imbalance.
Okay, makes a little bit more sense now. Okay,
right.
Sounds good. Thank you.
You know, and again, looking at some of these like the talofibular, the talocrural, and the subtalar. Honestly, most of the times I don't even remember those. I'm going to be 100% honest. But I remember my knee ones, right? I love how the going from the first metatarsal to the second to the fifth metatarsal, it changes. This is why when we get down here, they're not going to often ask you questions on your boards on these here. I put these on here so that you can have them for your boards, but they love asking capsular patterns about the hip and the knee because it's really simple, right? Hip is flexion, IR, ABD. Knee is flexion, extension equally. And I say equally means they have lost about the same amount of range of motion. So maybe you lost about 10 degrees of extension, and you lost 10 degrees of flexion. That tells you it's probably a capsular pattern versus a muscle imbalance problem. But again, like I said, you're going to run into clinics that are going to say capsular pattern, schmapsular pattern. They don't exist. So glenohumerals are typical shoulder joint. ER again, abduction, and medial rotation indicate a capsular pattern of the shoulder. That means I'm having problems going inward, having problems going outward, and I'm having problems bringing my arm out. When I have that going on, then I've probably got a capsular pattern of the shoulder, and I need to mobilize my shoulder.
And when you have to mobilize your shoulder, those are exercises that the PT or PTA tell you to do, correct?
Yes. So in the case, let's say the PT has done an evaluation, and the PT says, we've definitely got a capsular pattern of the shoulder for this patient. The PT is going to say, we're going to talk about the difference between an anterior mobilization, a posterior mobilization, inferior, superior mobilization, stuff like that. They'll say, we want to mobilize the shoulder inferiorly to improve range of motion due to capsular pattern. So then our job is to go and do whatever grade mobilization the PT orders us to do, as long as they're comfortable with us doing that mobilization. But again, according to the PTA, PTAs don't do mobilizations. In the real world, wink, wink, nudge, nudge, Bob's your uncle, we do mobilizations. I did this, said it again. So it's the PT is going to determine if this is a capsular pattern. What we have to understand is if the PT orders us to do mobilizations, why are we doing it? It's because it's a capsular pattern, not because they have a muscle. They may still have a muscle imbalance, right? They may still be weak. Their lateral rotators may still be weak, right? But that's not the only problem causing. The main problem causing it is that the capsule itself, the structure holding the shoulder together, is super duper Cooper tight, and we need to loosen her up.
Does that have anything to do with scar tissue?
With what? I'm sorry?
Does that have anything to do with the scar tissue as well?
Absolutely. So let's say I went into surgery because I had a rotator cuff tear, right? And now I'm come back to you 6 months later. You saw me right after surgery, right? And I was doing good, but I come back to you 6 months later, and now I'm like, man, I can't bring my arm out or in, and I just can't lift it out. And you're like, and you test me, and you're like, yeah, sure, you're more of a capsular pattern. Could be that I built scar tissue up on that structure that is now limiting my motion. You're absolutely right. That was good thinking. And again, it could also just be that, like your acromioclavicular ligament is tight, right? Or your coracobrachialis is causing problems, which is one of your stabilizers of the shoulder, right? So those are kind of some of the things we're going to look at when we're doing that. The main thing for you guys, you just kind of have to have this with you. I would definitely have this. I wish I had this when I was out in the field, because my capsular patterns crap was written all over the place. This is a nice kind of little chart for you guys to keep with you. It helps you out. Although I will say that I realized when I kind of typed this out and made this picture that that's supposed to be supination. Sorry. Even I make mistakes every now and then. I know it's shocking.
Are we gonna go over more in depth of closed and open pack too? Because we like briefly went over that.
Every joint we're going to.
Okay, cool.
Yep. So because with the next step after, so tomorrow we're going to start it. Tomorrow we're going to start with the hip. So in Therex, we're going to cover kind of exercises and pathology of the hip. And then in Kines, we're going to talk about open pack, closed pack, mobilization, goniometry, and manual muscle test of the hip. Does that make sense? That's the way I have my lessons kind of built in, is when we talk about one in one class, we talk about it in the other class, and they go kind of like this. Because in reality, when we treat, aren't we doing both together? I hope so. Everyone's just nod your head.
Yes.
Yeah, good. Thank you.
We're
It helps.
maybe a silly question too, but we're gonna go over like basically how to use the goniometer, right?
Yep.
I'm like, oh cool, these like degrees look awesome, but I'm like, how do I even
Oh
do
yeah, and again, so I have the first couple of days that we get back to lab are going to be some basic exercise days to get you guys back into the swing of being in lab, and then we're going to go through, and in Kines, when I tell you this is how you take range of motion of the hip, I'm going to demonstrate it, and I have videos to demonstrate it for you guys for every joint. Isn't that nice? So that if you forget, and Diana's like, I don't remember how to do hip abduction, and she's out in the clinic, she can quickly on her lunch go over and look at a hip abduction video and remember how to do it. See, I'm a nice person. Honest, I promise. I'm just picking Diana because she was last one to post. You guys, if you realize, just like I'm starting to get some of you guys are not even going to post anything in the chat anymore because you know that you're the next person to get picked on. So we talked about osteokinematics and arthrokinematics, right? The study of motion without regards to the forces creating the motion. So this is just looking at the way it goes. And this is looking at whether it's translatory, right? Linear, rotary, angular, or a combination of those two, where you have a little bit of both. And again, we talked about this with most joints in the body, we do a combination, right? We have a little bit of linear displacement. We also have rotation that goes along with it, because we don't just operate like robots, right? We move all around. When I'm sitting here talking with my hands, I'm doing rotational, translatory, and all kinds of weird motions. So arthrokinematics is the motion of the joint surface. This is that roll, spin, glide. It's really hard. And again, the arthrokinematics goes back to the capsular patterns a little bit in the fact that typically when you're looking at this, the rolls, the spins, and the glides are not going to be as smooth. So you'll notice maybe a little bit of hitching. They're going to lose range of motion. It's going to feel things, right? The range of motion itself is going to feel off. And it's not necessarily that you can measure it. Like you're not going, well, they've got a little bit of hitching here from 3 to 5 degrees range of motion. No, it's going to be a very subjective feel when you're moving them through their ranges of motion. Stabilization is the testing position for range of motion, meaning as we do any type of range of motion, we have to make sure we stabilize the body and the proximal joint segment so the patient can't cheat. For example, shoulder flexion, right? Shoulder flexion goes like this. A lot of patients, if they have limits in shoulder flexion, will come here and then lean their body. I got shoulder flexion, measure it, Mr. McKeever, right? And we've got to say, no, 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 not today. And we've got to limit them and say, okay, great. I'm going to put my hand here. Now you can't lean over. I'm like, oh, son of a gun. Now I've lost 60 degrees that I never had in the first place. So we have to stabilize and isolate motion to what we want to measure. If we're trying to measure abduction, we only want to measure abduction. If we're trying to measure flexion, we only want to measure flexion. We don't want to measure kind of accessory motion that they're causing with trunk flexion, trunk extension, stuff like that. So we've got to stabilize. Yes.
When you use the goniometry and you are testing for that, you don't stabilize the shoulder, example?
You will stabilize. Well, so the arm itself, we're not going to stabilize so much as the proximal component, which would be our body. Right? We're going to keep the body from moving out of whack because the arm we want to move, right? But we don't want the body to move if we're doing shoulder motion. If we're doing hip motion, right? We want the leg, the femur to move, but we may not want the low back to constantly rock into pelvic rotation. So we have to stabilize that pelvis so that they don't cheat. Because you'll find, again, when we start testing hip motion, some people will start rocking back into pelvic tilt in order to get more hip motion. And that doesn't test the actual motion of the femur and the acetabulum. Now you're adding that rotation, and you do get some cheater motion going on, if that makes sense. And they become cheater pumpkin eaters, and you got to call them out on it. And again, we're going to go over with each joint. This is how we stabilize. This is where you're going to put your hands. This is what you're going to block off. This is what you're looking for cheating. So that's kind of the idea for stabilization. So when is it a priority, or when is it kind of pointless to test goniometry? And when is it a priority to palpate? Well, I'm going to say it's a priority to palpate a patient all the time. Meaning we should always be getting hands-on, because again, like Dr. Ovreskin said, we don't test clothing, right? We don't test visually just by always looking at a patient. These are our best kind of judges of if patient's doing things right. Helps us assess if there's any spasming going on, if there's any skeletal alignment or misalignment going on. We can actually feel if they have tightness of the muscles, right? If you put your hand behind your hamstring and you kind of lean down, you can feel when that hamstring starts getting tight, just because you can get that nice, proprioception in your hand. You can measure if they've got poor habitual posture, right? If I touch somebody, I can feel like if I was sitting like this, you could come along and feel that my thoracic vertebrae are kind of poking out through the back of my back. They help us assess atypical movement patterns, looks at that limited range of motion, and can help us itemize muscular pain, going, does it hurt with this muscle here when I palpate it? Or does it hurt with this muscle here when I palpate it? Gives us an idea. Why would it be pointless? If the patient has psychosocial issues. So what may be a psychosocial issue that we would not want to maybe touch a patient? Can anyone think of any?
You should ask permission if they have PTSD.
Right. Good example. And I hate to use this as an example, but if I have a lady that has suffered some sort of sexual assault and I go to touch her, could that trigger a PTSD response? Yeah. Right. I mean, I'm not exactly the most friendly looking person in the whole wide world. I'm kind of scary. And so they may, or I may even just look like the person that assaulted them, and that can really cause some trauma, right? So if there's psychosocial issues there, be aware and don't touch your patient. Ask them, is it okay? And if the patient says, I want you to stop, what should you do? Stop. Yeah, right. They're not saying that because, well, I don't know, you have bad breath. Maybe they're saying because you have bad breath. They're saying because it's causing them a psychosocial issue, a problem with their actual ability. And it may just be you, right? Maybe Riley's working with me. Yep, you would report that in assessment, Joe. Great job. Look, see? You guys are starting to get it. You see that? Look, right? Number one area I'd report that even before I reported the assessment is I'm just going to let the PT know flat out, right? I'm going to let the PT know that, that it just wasn't working. So Riley could be working with me. And for whatever reason, maybe when Riley comes into the room, her personality just rubs me the wrong way. I don't know what it is. Maybe it's just one of those things that she reminds me of my lost, estranged daughter who doesn't want to talk to me anymore. And her voice reminds me of her, and everything she does, her mannerisms remind me of her. And every time she gets close to me, I kind of tense up and I get angry. And Riley visually sees this. And, she's like, can I touch your shoulder? And I'm like, yeah, if you've got to, right? That may be a time where I may have to have a conversation with the patient and say, I don't feel that we're kind of working very well together. Is there a problem with me that you don't like? And maybe one where I say, yeah, you really remind me of my estranged daughter, right? And that would be a time for Riley to say, would you prefer to work with somebody else? And that's okay, right? Patients sometimes just have problems with us. I know a lot of patients, well, not a lot, but I know some patients that have problems with me. It's okay, right? It's not personal. It just is what it is, right? Some patients, some ladies prefer working with ladies. Some ladies prefer working with men. I've seen that. Some men prefer working with ladies. Some men prefer working with men. I've seen that. It's not anything personal, and it may not always be feasible. You may have to tell them, I can appreciate that you want a different PTA or PT. I'm the only one here that can work with you today. Let me talk to Dr. Vreskin tomorrow and see if we can put you with one of our other PTAs. Can we agree to that? Let's just get through today. And I would report that in assessments. And I would say that the patient had, visual discomfort while I was working with the patient, right? And that kind of gives me stuff. If they're in extreme levels of pain, probably not a good idea to touch them, right? If they're like, what's your pain level? And literally they're like, it's a 10 out of 10. And they literally look like 10 out of 10. Maybe it's time to send them to the hospital more than, hey, let me touch that shoulder and see what's going on. If muscle length is not related to the patient's condition, meaning that we've got something going on where it's not necessarily a length issue, the muscle ripped off the bone. That might not be a good time to touch that patient. That probably hurts. I'm just saying. I saw one patient that came in, I'm not joking, the one clinic that we had, he was coming in to see us he had some bicipital problems, so bicipital tendinosynovitis. And he comes in 2 days later and he's like, I just really can't bend my arm anymore. I don't know what's going on. Something's going on. And I looked and his bicep is all rolled up here. He had a Popeye tear. His little bicep ripped off his lower arm. And for whatever reason, it didn't hurt for him. That's probably not a time. Hey, let me touch that and see how, does this hurt? Stop it. If joint motion is prohibited, if we have something like a total hip replacement and we're not supposed to go into extension, don't do it. If there's severe inflammation, right? What happens, I have a patient that's got an elbow fusion where their elbows fused at 90 degrees because that's functional. That's not a time we're going to palpate and try to extend the elbow. If they have an elbow fusion, it's fused, right? You're not going to want to try to extend it. So what kind of tools can we use for goniometry? We've used tape measures, manual and universal goniometers, manual and digital inclinometers, cameras, electrogoniometers, gyroscopes, motion analyzing systems, and even smartphones nowadays. So these are our kind of universal goniometers, right? All of you have seen at least one of these, correct? At some point, either in a picture or I held one up or something to that effect. Yes?
Yes.
Good. These are the ones we most use. Why? Because they're cheap. If you want me to be 100% honest, they're cheap. They cost between $5 and $100. Most of them are like $5, $10. I'm going to tell you something. Here's a secret. Shh, don't tell anyone. We're going to give you a goniometer. Don't tell Dr. O'Neill I told you that. We're going to give you guys a goniometer and a gait belt because two of the main tools we need as PTAs are, guess what? Goniometers and gait belts, right? ABGB, you got it, Anthony. I'm proud of you. Obviously, the more expensive the goniometer, the more fancy type stuff it does. I bought a fancy goniometer for our clinic that has extendable arms. So if you're testing like the leg and the person's got a really long leg, you can extend the arms on the goniometer to give you a little bit more length. Those get a little more expensive. You also have gravity dependent goniometers or inclinometers. These are called bubble gonies. And they have a fluid in them. And we're actually going to use those on the spine that as the patient moves around, gravity moves the fluid inside the goniometer or the pendulum, right? And actually measures devices. Those are expensive. There's a reason why we keep those locked up at school because bubble gonies are like $60 on the cheap end, $400 on the expensive end. But we will use those specifically for the spine because they make spine measurements really easy. So here's looking at you, kid. Here's a universal goniometer, right? So when we're looking at it, our fulcrum is our vertex when we talk about angles. Our stationary arm is typically going to go along the body. And then our moving arm is going to go with the limb that's moving, right? So if I'm doing elbow flexion, the part of my arm that's going to be stationary is what do you think? Which bone? Take a guess. Humerus. Yeah, because it's pretty funny. Okay, that wasn't that funny. Where do you think my vertex is? What bony prominence?
Lateral epicondyle.
Yeah, one of the condyles. Good. That's a great, perfect idea, right? And then my moving arm is going to go along what?
Radius and ulna.
Yeah, the radius and ulna. There you go, right? And then each of them are going to have a proximal bony prominence and a distal bony prominence. Right? So for the example, the stationary arm, the bony prominence is going to be our greater tube. And our distal bony prominence is going to be our styloid process. We'll learn that with elbow flexion, but it's just kind of an easy example there. Electrogoniometers are really expensive. Look at that, $40,000 to $200,000. They seem to resemble pendulum goniometers, but instead they're basically like little electrodes. The good news for these is these are used in research. Yeah, Harley's like, yeah, I'm not going to buy any of those. They're mainly used in research to be very, very highly accurate. And the other thing is they exhibit real high test retest reliability, meaning if I test over and over again, I get the same results over and over again. You're not going to see these in clinics. The only clinics I ever see these in are workers' comp clinics, because again, workers' comp clinics often require very specific measurements. X-rays and imaging. We can use them, but the downside to X-rays and imaging is we expose people to radiation. And we know that radiation opens us up to what?
Cancer.
Cancer, yeah, right? Can also do digital radiography, which uses a little bit less radiation, but to me, I'm just going, any radiation is bad radiation, right? You have about a 1 in 100 shot every time you get an X-ray of getting cancer. And that goes up with about every X-ray you get. We can do photography, absolutely. I could take pictures of Riley when she's at neutral, at mid-range, and at full range motion, and I can measure off that. It's good for kind of giving the patient a view of what they're doing, but it's more time consuming, right? When we take photographs, it's taking extra time up, and that can really kind of bog down your day doing that. It also may be more difficult to access. Perspective errors may occur. It's harder when you're not touching the bony prominences. Smartphones, there are all these kinds of data apps out there for it. I don't know which specific app these are. I'm sorry, I don't know. I just found them on the interwebs, the intertubes, right? But there are a bunch of different smart apps out there for goniometry. The problem I have with this is the reliability and validity of these tests are really, really insufficient, meaning they're all over the place. Some may be really accurate, but aren't very reliable, meaning they can't repeat the results. Some aren't valid. You know, in the future, do I think that smart apps might be a way to do goniometry? Sure. You know, if we can get to the point where we can just put little like magnets on their arm or something like that and they move and the smart app measures the motion of the arm, yeah, absolutely. That'd be awesome. But we're just not quite there yet. But they're out there. And if you want to find one to play with, go ahead. Most of them are expensive that I saw. Like, I think this one over here, the one on the far left is like $200. And I'm sorry, why would I pay $200 for a smartphone app that I can use a $5 goniometer for? I'm just saying. Visual estimation yields only subjective information in contrast to objective goniometric measurements, meaning don't always rely on your visual estimation. That being said, visual estimates give us a good idea prior to doing a goniometric measurement, meaning we can look at a shoulder and go, oh, well, they have about 100 degrees range of motion. And then when we measure it, we can go, yeah, we got 105. That was about what I estimated. I'm the kind of nerd that likes to be that challenging person that goes, when you guys are testing goniometry, I'm walking around going, it's about 85 degrees. And then I want to see how close I can get to your actual measurement, because I like things like that. That triggers some dopamine release in my head when I can be really accurate on just visual estimates. We may want to look what's within normal limits, within functional limits visually, just to see how they're doing, right? But again, it's very subjective. Are they severely limited? Are they moderately limited? Are they slightly limited? It's a lot better if we actually have a true measurement from a goniometer. But, you know, if Uncle Bob comes to you and says, hey, you're studying that physical therapy stuff, what do I look like I can't move my arm as far as I could? And you see Uncle Bob can only lift the arm up to that. They go, yeah, Uncle Bob, you probably are missing a little bit of your shoulder flexion there. You may want to go see a PT. Well, thank you. Right? I don't know why Uncle Bob's a redneck, but all my people are rednecks, it seems like, doesn't it? Goniometric measurements are going to be measured and recorded in tables. We may take pictorial or charts to show how it progresses over time. It may be written in the text of an evaluation, or we may take some photos. The main goal is to show progress, right? Or to show regression if the patient gets worse. In the case of something like muscular dystrophy or ALS, the patient's actually going to get worse, so it helps us show how they're regressing or getting worse. All right, I'm going to just mention this, and that's as far as we're going with this. Sagittal frontal transverse rotation. That's a lot of stuff. These are 3 numbers to use to describe all motions in each plane. This is looking, remember how in math class you had the X and the Y axis? Do you remember that? The standard plane? Does everyone remember that? The coordinal plane or the cardinal plane, whatever it's called. Yeah, my brain's not working right now. With
Yes.
SFTR, we now add the Z axis. So this is doing a 3-dimensional range of motion measurement. It's not common in the United States, but in clinics, especially over in like Germany and France that use this, it can be much easier to understand because it takes into account not only going in one plane, but what happens in the rotational component of the shoulder, so we can help determine if it's maybe capsular or non-capsular. So you just have to know that, again, we don't really deal with this, but this adds a 3-dimensional motion to goniometry. So the AMA guidelines are what we're going to go off of out of your book. It uses the 0 to 180 degree measurement. I will give you the specifics I want you to remember for each joint. Thank you, Mr. McKeever. You're very welcome, Riley. I appreciate you saying thank you. You're going to have specifics just to memorize that an elbow should be this range, a hip should be this range. There are other ones out there. There's the American Orthopedic Association that has range of motion measurements. If your clinic uses those when you're on clinicals, just use them. Extension exceeding the neutral starting position is expressed with the plus symbol, is what the AMAs go. We will actually use that 3 system where you go, okay, 6, 0, 180. That's what we will use in our class. So what are some precautions? Well, we want to make sure that we need to make sure that if there's any problems in the muscle length, we understand what those problems are, that they don't have any new tears. Make sure the joint's not dislocated or subluxed. Make sure they don't have any unstable fractures, right? We talked about this before. What is your number one, if you can't remember a contraindication to a treatment for almost all of your comps, the number one answer you can give is what?
Malignancy.
Malignancy and unstable fracture. There you go. That keeps you safe, right? Because an unstable fracture, if we move it, or what are we going to do to it? We're going to make it more unstable, possibly puncture something, right? If you move somebody, have them do extension of the back and they've got a broken rib, could put that rib through the lung. Don't want to do that. If they've got a rupture of tendon or ligament, not a good idea to range motion that. Bad. If they have an infection in the joint, such as like gout or something like that, you want to watch out. Severe osteoporosis. If they're really, really, really osteoporotic and you move them through some range of motions, what could happen? What could you do to them? So my bones are all holy and airy, and then you move me, you could literally do what?
Fracture.
Yeah, fracture, break my bone. Any new acute or recent surgery. That's why when we come to the patient and say, hey, my name is so-and-so, I'm going to be your physical therapist assistant for the day, student physical therapist assistant. We're going to do some goniometry today. Is that okay? Do you have any recent malignancies, new fractures, any new acute injuries or surgery since the last time we came to you, right? That gives us an idea of what's going on. Ask them if they're having any spasms. And if the joint is immobilized, if they're in a cast, or again, they have an arthrodesis where the joint is fused, you're not going to be able to range of motion them. Just saying, I've seen that. I know that this seems silly that you guys are going, well, if they're in a cast, why would somebody try to range of motion them? If they had to put it in the book, that means what? Somebody actually did it at some point. Somebody tried to range of motion somebody in a cast. It's kind of like, why did McDonald's have to put caution, coffee may be hot on their coffee? Because somebody thought, well, this looks like a good thing to spill on my lap. Because we've got to play to our lowest common denominator, folks. What can limit range of motion? Pain, right? Structural blocks, joint effusion, pretty much anything can limit range of motion. So we just have to be aware of that. So how do we prepare for testing? We determine if there are any contraindications. We ask that. Determine if the joints that we need to measure. So we need to have an idea. I need to measure elbow flexion, elbow extension, pronation of the forearm, supination of the forearm. Get all your equipment together. Prepare an explanation. Understand what you're doing. Minimize position changes. We're going to talk about this when we do goniometry because some will do on the side, some will do prone, some will do supine, some will do seated. If you constantly have that patient changing positions, they're eventually going to get irritated with you. So you want to try to group your goniometry measurements so that you do all of your prone stuff first, all of your side lying stuff, and all of your supine stuff, so that you keep the patient in one position for an extended period of time. Test the unaffected side first, if possible. Why would you want to test the unaffected side first?
You want to see the
Okay.
normal range of motions?
Good. What if my unaffected side is 100 degrees? And then you come over here and my affected side is 90. Well, that's only 10 degrees difference, right? You don't have that far to go. They're still short, but you're only 10 degrees away. Makes you feel a little better, right? Makes them feel a little better too. But then you can go, hey, we got to work on that other side too, maybe a little bit, right? It also helps you give kind of that baseline, like you said. You're always going to do passive range of motion first, meaning you're going to move them through. That does two things. Number one, you get the end feel, right? And again, if it's ouchie, 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 stop, great, we have an empty end feel. But most of the time, you're going to get most of the range of motion and get that end feel. The other thing it does, it gives you an estimate of where you're going. You know, how far do you know to take? How far can they take it? It also can tell you if their passive is way more than they're active. Like say you test their passive and they're all the way out here at 180, but then they actively contract and only go to 30. That's weird. That's something we could put in assessment, right? And then we're going to have them test active range of motion. And we're going to use Mr. McKeever's technique for this. What is Mr. McKeever's technique? We are going to give them STDs. I am going to show them what test I'm going to do. So we're going to test your elbow flexion. So I'm going to move your arm through a motion like this, right? So now I'm going to do it. I'm telling them. So what I'm going to do is I'm going to move your hand up towards your shoulder. Good. Now get lined up. Now I want you to do it. That show, tell, do really helps them understand what's going on. And for those of you that are parents, you probably already do a little bit of that, right? When you want your kid to do something, if they don't know how to do it, you typically have to show them and tell them what to do. Sometimes more than once. Take out the trash. I already took out the trash. Did you really take out the trash? Trash is full. Oh, Mom. And does that sound ring familiar for anybody? Or maybe way too familiar?
Too familiar.
Yeah, too familiar. So when you come in, you're going to explain, introduce yourself, tell them what you're going to do, tell them what position they're going to be in. Why is that position important? This is going to make it easier for you. It's going to be more comfortable for you. Explain what you are going to do and what you expect from them. And then also do the procedure in a method that is consistent with your explanation. If you tell them this, you know, I'm going to move your forearm up, your fist up to your shoulder, and suddenly you're going out to the side and they're like, what are you doing? They're not going to trust you as much. So make sure what you do is actually what you tell them you're doing. So this is the 12-step sequence. Position the individual, stabilize the proximal joint segment, move the distal joint to the 0 starting position. Make sure they're at 0. Test the passive range of motion. Return the distal segment, palpate the bony landmarks, align the goniometer, read and record the starting position, stabilize again, let them move it through, replace and realign the goniometer and palpate the landmarks again, read and record. So a lot of that's like really kind of what is this saying? So what it's saying is put the person in the position you want to test them in. Once they're in that position, make sure everything that doesn't want to move is stabilized. Move them through the range of motion, right? That's that show and tell part of, right? Line up your goniometer with what you need to line up with, the bony landmarks you need to measure. Once you're lined up with that, have them move it. So they're going to move into elbow flexion. Then you're going to have to make sure that your goniometer is still on those bony landmarks. Because guess what happens to bony landmarks when people move? They move. So make sure you're still on them. And then once you have your bony landmarks lined up again, take the measurement again, and that's it. I know that this list looks really kind of cumbersome, but it's not. You're going to put them in the right position, stabilize, show them what to do by moving them through passive and get an end feel while you're doing it. Line up, have them move, reline up, and measure. That's it. I know it's 12 steps, but Mr. McKeever prefers the 6-step method of keep it simple, stupid. I think you guys prefer that as well. So this is kind of my Keep it simple, stupid method. Also, don't get in the way. If you're trying to move them into elbow flexion, you shouldn't have a hand in here blocking their elbow flexion. So think about that when you're doing it. Get yourself out of the patient's way. If they have to do abduction, you don't want to be standing out here on this shoulder because they're going to smack you when they go into abduction, unless you want to get smacked by your patient. Then that's up to you. We'll talk about the difference between goniometers and inclinometers when we're in the clinic, and we're actually in, especially when we measure the spine and specifically motions of the head. I, even as a clinician, use regular goniometers for the spine, but a lot of clinicians prefer inclinometers. I'm just much more comfortable using a big bad goni than I am with using those stupid bubble goniometers. I don't know what it is about them. They just don't hit for me. I just don't get it. So I prefer using my big old bad goniometers, my baby gonies, than I do using something fancy schmancy with the fluid in it. Although it's blue and it's pretty. All right, we're gonna change gears. We're gonna go from goniometry, and again, we're gonna do that with every single segment. So don't totally freak out. I'm gonna demonstrate goniometry for all the joints we have to do. So don't totally freak out yet. Riley and Diana and whoever else is, Brooke probably a little bit there. We're gonna go through them all together. So don't you worry. That's the point of teaching. Brooke's like, yep, I was already kind of freaking out. So manual muscle testing with goniometry is to measure our range of motion. Manual muscle testing measures our strength. And again, it's assessed relative to the patient, not to us. I'm pretty sure I could put most of you guys with somebody else in the class that is going to be stronger than you are, right? If I have little old Millie and I'm like, okay, Millie, I want you to do elbow flexion. And I'm like, go ahead and resist me. Millie's like, what? What? Because Stone Cold says so. No, you've got to measure it to that patient, right? Not to you. You may be stronger, you may be weaker. Kind of like myotomes. Exactly, Diana, right? That's why we taught that first. That's kind of fancy, isn't it? And again, what happens if you're weaker than the patient? Well, that's okay, right? Honestly, if you're weaker than the patient and say Diana's testing, I don't know, an NFL player's hip flexion, and that player can lift Diana off the ground in hip flexion. Can we pretty much be confident that their hip flexion's okay? Like if he can pick her literally up with hip flexion, I think we can pretty much say his hip flexion is probably within normal limits, right? So that's the thing. Even if you're a little weaker, it's okay. And I'll teach you methods to apply your force that kind of put your body in good position that you can use your body to resist it as well. Strength is the amount of force produced by a muscle or muscle group to overcome resistance, and it can be limited by many conditions. Functional movement does require one or more muscles to act as prime movers and oftentimes stabilizers as well. So why should we assess this? Well, manual muscle testing helps us determine if there's a dysfunction. That's the main thing. It helps us determine if there's a problem with the patient in general. Could be postural muscle length, could be presenting conditions, could be differences in range of motions. Those are the things we're going to kind of go, okay, what is causing this? Testing muscle testing. Oh, well, they're missing 30 degrees of shoulder flexion because their anterior deltoid is weak. And it only lets them go to here, and then they kind of get stuck. So we need to strengthen that anterior deltoid. That helps us. It evaluates patients' ability to recruit muscle groups to produce forces in cardinal planes. Oh my God. Okay, so I put this chart up there. How many of you guys are freaking out right now? Okay, Diana admits it. Good. Well, I got some positive news for you, right? So this is kind of the standard chart here. But what you're going to find is in most clinics, we avoid those pluses and minuses in 3 greater. And I'll talk about why in a little bit. So you only have to remember a plus and a minus down there in the 2s. So it will be easier than you think. And I'm going to break it down really quick. So these are 1 through 5, or 0 through 5 is our measurement, right? 0 meaning nothing's happening. This kind of looks like testing myotomes, doesn't it? Guess what we developed myotomes off of? Yeah, we developed it off manual muscle testing. So here's kind of just the numeric values if you're just testing it. So I'm going to demonstrate one just so that I hope it helps it stick in your head, because we're going to talk about the technique in a little bit. So a 0 on a manual muscle test means there's no motion. Nothing happens. You put your hand, like if I'm testing elbow flexion, you put your hand on my bicep and you're like, okay, bend your elbow. And I go, I am. And your fingers are all on my biceps, all on my brachialis. Come down, feel the brachioradialis, and nada. You get nothing. Maybe I'm a spinal cord injury. That would be a good reason to have that. Or maybe I'm a stroke, right? A 0 means there's not even a twitch. There's nothing going on in the muscle. It's dead gym, right? For those of you that are Star Trek fans, it's dead gym. I'm a doctor, not a manual muscle tester. Trace. Trace means that you put your fingers on my bicep and you feel a quiver. Something happens. I may not get any motion, or I may get super duper minimal motion, but the muscle twitches. You're like, okay, there's something there. 2 means that I can move my arm through the range of motion, but I can't do it against gravity, meaning I have to eliminate or minimize gravity. I know it says omitted, but you can never really eliminate gravity. I hate gravity eliminated. It's not really a real term. It's gravity minimized, really is what it is. 3 is kind of where we're always going to start assuming with patients, that they can try it against gravity. So in biceps, I'd want to be seated so that I can come up across gravity. Right, and we're going to eliminate compensation. We're going to talk about that in stabilization while they do it. So if I'm just testing the biceps, I want to make sure that I don't activate some of my shoulder flexors. I maybe don't rotate and activate brachioradialis. I mean, not if you put your palm down, you fire off more brachialis more than biceps. So there are specific positions we're going to put the patient in to avoid that compensation, Diana. So great question. But in the case of biceps, you're going to put the patient in short ceiling, so sitting at the edge of the bed, and you're just going to have them lift the arm up. And if they can go the whole way against gravity, that's a 3, just like it was in myotomes. A 4, they're going to go the whole way against gravity, but now you're going to put some resistance, and as soon as you push against their hand, it breaks. If you push it against it and it breaks, that's a 4. And then 5 is where you put your pressure against it, and you're like, "Urgh," and I'm like, I ain't going nowhere. I ain't going nowhere, copper. You ain't taking me nowhere. And you see, right? And I'm resisting you, and you're like, man, he's strong, right? I wish he'd take a bath. No? Darn it, tried. Try to make this a little funny. I know, I'm failing.
I appreciate the humor.
Good, I appreciate that. So for our class, in most of the clinics in our area, we're going to use our whole numbers only, with the only exception of a 2, and I'll explain that in a little bit. You may encounter on your boards those plus or minus grades, but probably not. We're getting rid, Amanda's stressing out. Good, I like that. Why are we getting rid of those plus and minus grades? Because by research, we've deemed that those plus and minus grades are really more subjective than they are objective, right? A 4+, if we go back up here to this long one, a 4+ holds test positions against moderate to strong pressure. Well, is moderate to strong pressure different between me and Amanda? Well, maybe not. I don't know. Maybe Amanda's moderate and strong pressure might be the same. Right? But maybe Anthony's a little bit stronger than both of us, so his moderate to strong pressure is more. That doesn't make sense. Understanding that they resist and don't break is very clear. That's why we tend to stay with just the single numbers. When we are doing this, we are doing a break test, like I said, but don't tell them, don't let me break you. Say stuff like, don't let me pull your arm down. Don't let me push your arm out. That type of thing, because when you say break, it puts a negative connotation in the patient's head. And like Amanda is stressed out right now, the patient will get stressed out. And we don't want that, because if Amanda and her patient are stressed out, it's a bad day. Right? We got to have at least one of them not stressed out.
So you're pushing against them and they're trying to hold that.
Yeah. So in the case of like elbow flexion, right? I'm going to go up with my fist. So that means my resistance is going to go
against
down. Yep.
Okay.
And again, we're going to go through each of the muscles individually. So don't totally stress out yet, Amanda, I promise you. The application of resistance, if you have a one joint muscle, it's going to be at the end range. So if I've only got one joint muscle, like let's talk about wrist extensors, I'm going to test them when they're in full wrist extension, right? But with my biceps, it crosses the shoulder and the elbow. So with that, I'm only going to test it at mid-range. I'm not going to test it way up here because I've got some active insufficiency up here and you might break me up there. So I'm going to test it at about 90 to 100 degrees, somewhere in that range. Again, not an exact science. You're just not going to test it way up here and you're not going to test it way down here. Somewhere in that mid-range of my range of motion. Does that make sense? And when we do it, you'll see, once we start getting hands-on, it will make sense. The resistance should be slow and gradual. I recommend counting for 5 seconds. So don't let me pull you down. Here we go. 5, 4, 3, 2, 1. Great. Good job. That gives the patient an idea how long they have to hold your resistance for. If you're like, don't let me pull you down, and you're like hanging on them for an hour, it might get a little stressed out, right? We all know kids that love to like hang off our arms and our shoulders. Well, we don't want to be that to our patients. Precautions and contraindications. Unhealed fractures, again, definitely don't want to do manual muscle testing against it. Pathologically unstable joints. If there are bony blocks in the joint, meaning there's bones there that shouldn't be there, don't want to test manual muscle testing. If range of motion is not allowed, don't want to test it. Advanced osteoporosis, metastatic cancer, osteogenesis imperfecta. I forget which one he asked about this, but man, that's a pretty bony subject, right? But osteogenesis imperfecta, if they've got brittle bone disease, definitely don't want to be pulling on their bones because we can break them. So we have other techniques for testing their strength versus somebody that's got regular bones, regular bone density. There's a science and art in MMT, right? Science talks about some factors affecting test accuracy, meaning, are you testing the same way every time you test the patient? You have to understand the anatomy and biomechanics of the joints. Know your O's, your A's, your I's, and your innervations. Understand how to stabilize their joints. The art in it is handling an injured patient, right? Because we are going to test both sides. Yep, I'm going to talk about the full technique coming up here, Diana. Because again, we have to have a normal test, right? Because what if a 4 is their normal? That may be their normal. It doesn't mean that we're not going to rate them a 4, but it tells us, oh, okay, well, this is where they are normally. We may have to strengthen both sides. You want to gently test weakened muscles and even weakened joints. And you want to allow the resistance or apply the resistance in a manner that allows the patient to produce optimal force, not where they're at a lockout or where they can't be optimal in their force. So technique for it, you're going to put the patient in the proper position. You're going to move the patient through the passive range of motion. That looks a lot like goniometry. Well, why? Because that demonstrates to the patient what they're going to do. You're clearly going to tell them, so I'm going to have you do that same thing. I'm going to push. I'm going to pull. I'm going to move you in. I'm going to move you out. Don't let me do that. Be very specific in your directions. If I'm going upwards and I'm pushing down, don't let me push you down. Don't let me pull you up. Don't let me move you out. Don't let me move you in. Those are the kind of simple phrases you want to use. When you say, don't let me break you by pulling you downward with maximal suboptimal force created by my own arm, the patient's like, what? I'll get what you just said. Make it very, very simple. Again, 7th grade education here in Nevada. You're going to have the patient move the whole way through their range of motion. And then you're going to have them perform that action again and begin applying your resistance somewhere between 50 and 75%, avoiding those bony lockouts. Apply the resistance in a firm and consistent manner, and then record. So we're going to do right, then we're going to do left. Why again? Because we want to have bilateral measurements. We are going to do comps on these. Oh God, a comp. Don't worry, they're going to be simple. You will have to test bilaterally. The main thing with bilaterally is if I tell you, test the left arm biceps for manual muscle testing, and you're effective on the left arm and you say, okay, now I'm going to test the right, I'm probably going to tell you, okay, you did good, move on. Right? So that's kind of the test we're going to do. And we'll go through the comp itself, so don't totally start freaking out about that, Amanda. We have to make sure they're not substituting, right? We have to make sure we are able to palpate a contraction. So we have to use both hands. May not be the best idea to test manual muscle testings after you've done all their exercises, because at that point they're going to be what?
Fatigue.
Yeah, fatigued or tired, right? Make sure you test it at the same time every treatment session. If you test at the beginning, test at the beginning. Patient has to be honest with you, and you have to be honest with the patient. If there's a language barrier, could that cause problems? I've had it.
Yes.
Right? Yeah. Right. Sometimes I think you guys have a language barrier with me. Just joking. I'm just kidding. And then also understand if they have limited range of motion. Right? Can we trust this test? Manual muscle testings, we can. Right? So what can throw the results off? Can it be repeated by the same person and on the same person? That would be intra-tester and intra-rater or intra-subject reliability. Can it be repeated? Right? Is it valid? Meaning, are we able to measure statistical acceptable variability? Are we able to determine if there's a slight change? They've gone from a 4 to a 5. All that comes into play. These tests are very reliable, and that's why we do them, because they are related and pretty simple. More than likely, by the time you guys are out there full-fledged for several years, we're going to be moving to hand dynamometers, which are little pressure plates. And you wouldn't even have to remember the 5-to-1 system anymore. You're just going to measure in pounds of force, because I think that's the way we're eventually going to go with manual muscle testing. So you have to learn something totally new. Why is it a priority? Well, it helps us tell about soft tissues, dysfunction, and condition. It also helps us determine functional deficits and gives us a natural progression. When would it be pointless?
Here's what I found.
When would it be pointless? If there's a contraindication to contraction, meaning they're not supposed to be able to contract. Don't do it. If they just had a reattachment of a muscle, that may not be the best time to test their manual muscle testing. If they're in high levels of pain, again, like range of motion, we don't want to do it. If they're unable to isolate motions, that means they're only able to cheat. It's pretty much pointless to test manual muscle testing, so we're not getting an accurate result. Wow, that was a lot of unintelligible stuff, Mr. McKeever. Why did you make us go through all of that? Well, because we are going to go through that with every single joint and every single part of the body. So we're going to start with the hip. We're going to go down to the knee. We're going to go down to the ankle. And we'll talk about the toesies, but we're not going to hit too much about the toesies because, again, not very common that we measure manual muscle test strength of the toes. No, we'll actually do upper extremity this semester too. You just do exercises of upper extremity next semester with Dr. Reskin, but we will do manual muscle testing so that it's easy for you to understand what she's talking about. Because the number one thing we want to do is figure out what you're talking about, Willis. Some of you get that, some of you don't. I get a smile from Diana, I appreciate it. Yeah, it'll be very hands-on. And I'm going to demonstrate it just like we did with those exercises. I'm going to demonstrate it through the lecture, and then we are going to do it when we get to lab, because that way I don't have to reteach you. I may have to teach you a little bit, like Stephanie may go, yeah, I don't remember how to do pronation, supination. That's okay, right? But she maybe remembers elbow flexion. Great. That saves me having to teach that over again. Those are the things that that's why I'm going to show you before we do it. Physical therapist. Yes, we're physical. Exactly. But if you look, I know goniometry and manual muscle testing looks kind of intense, but we're not camping, so it's not intense. No? No, Amanda's shaking her head. Okay. You're online therapist right now, but you will become physical. Don't worry. I promise you. And we will do this. And again, like I said, we're going to cover it. So I'm going to start with the hip, then we're going to move to the knee, the ankle, and the foot. Then we're going to go up and we're going to cover the shoulder girdle. So all of the scapula, clavicle. Then we're going to move out to the shoulder, the elbow, the wrist, and the hand. And then we're going to cover the whole body, the neck or the spine, so cervical, thoracic, and lumbar. But Dr. Reskin's going to cover exercises of those, whereas I'm just going to teach you how to move them. Pretty simple, I promise. It's a lot easier than you think it is. I know it looks difficult, but I promise you, if I can do this stuff, you guys can do this. I'm not a genius. I just play one on TV or on Zoom, I guess, more than TV. Are there any questions for today? If not, I'm done rambling.
I have a question, but I'm gonna wait towards the end.
Okay, so I'm going to stop recording.